Let the adventure begin. Welcome, everyone. I'm Laura Gottlieb, founding co-director of the Social Interventions Research and Evaluation Network, probably more familiar to everyone as SIREN. Welcome to today's Research to Disseminate webinar. Just going to give folks another moment and do a little bit of logistics. But first, let me just say, usually our team members rotate through the host role for SIREN's webinars. Today, we have the exciting and I'll admit a little intimidating opportunity to actually be the presenters. It brings me enormous delight to introduce my brilliant friends and partners in crime at SIREN, Danielle Hessler-Jones and Caroline Fichtenberg, without whom I would not enjoy my job at UCSF nearly as much. So welcome, Danielle and Caroline. Before we dive right in, I've been tasked with this responsibility of sharing both webinar logistics and some news about upcoming events. First, the webinar is being recorded. We will send a link to the recording to all registered participants when it's available. It will also be on our website. We welcome your questions and comments. Please use the Q&A function, not the chat function, to ask your questions and to add comments. We will be monitoring Q&A, not the chat function. And then this is certainly the right audience for sharing details about two upcoming webinars that we're developing with our friends at the Camden Coalition, both of which are about their care management randomized control trial findings. Speakers for the first webinar include MIT's Amy Finkelstein, Camden Coalition's Kathleen Noonan, and Erin Truchel, Institute for Healthcare Improvement's Kedar Mate, and the marvelous Damon Francis from Alameda Health System. In the second webinar, the Camden Coalition team will moderate a panel with 4 of their consumer scholars to explore their perspectives about the study findings. The QR codes here will take you to a registration page. Same information is available on our website. We'd love to see some of you there. All right, so let's get back to the content of today's event, which will be a discussion about the evolving conceptual model for social care in healthcare delivery settings. Today's presentation and discussion stems from a paper we've been chewing on at SIREN for a very long time, at least since 2016. It was published in January of this year in Milbank. Many thanks to Milbank Quarterly and their team for helping us do that. And yes, sometimes it does take that long for a paper to get written. The paper is open access. It's available online for those of you who haven't seen it yet. But today I'm going to give you all the Cliff Notes version of the paper. So first, the key one-liner. This paper synthesizes some of the research that has helped us at SIREN understand the mechanisms through which social risk screening and interventions appear to influence health and healthcare utilization. Before diving into more detail about what we wrote and why, I want to share 2 thoughts. And I'm hoping that's 4, but actually I only have 2. I'm hoping you'll keep them in mind throughout today's conversation and ideally beyond. The first comes from the British statistician George Box, who said, all models are wrong, but some are useful. So I know most people don't start their presentations this way, but let me be the first person to say that the model I'm going to share is probably wrong. At the very least, it's missing some key details. There are many other pathways to health. That said, we very much hope it may nonetheless be useful, particularly if it means that collectively, people investing in integrated care will continue to unpack the many mechanisms through which social care activities might influence health. There's one other clever phrase that might be familiar to many of you and I think might help shape our conversation. It's another oldie and a goodie. Frameworks are like toothbrushes. Everyone has one, but nobody wants to use someone else's. It turns out that attributing that quote is not as straightforward as the George Box quote, but I love it nonetheless. And I hope you take it as an invitation to adapt and improve the model that we are going to present today and make your own more colorful version. So with all that in mind, let's talk about what I think to date has been the foundational conceptual model for social screening in healthcare settings. As most of you know, screening for social risks and needs is quickly becoming a cornerstone for standard setting bodies across the United States. The Centers for Medicare and Medicaid Services, the Joint Commission, the National Commission on Quality Assurance, all as examples, have established new quality measures related to screening for health-related social needs. No matter how you particularly feel about social screening, I think all of us recognize that screening's champions, including those standard-setting organizations I just mentioned, believe that the goal of screening is to identify select risks, intervenable risks, connect patients with relevant social services, and thereby improve health. It makes great intuitive sense, I think. Person has social risk, I connect that person with a social service. Ideally, they get the social service, the person's risk decreases, and health improves. The evidence for this intuitively obvious and appealing pathway is still being established. There are lots of questions about how it works. For instance, even if we assume that asking about social conditions in a healthcare setting leads to the disclosure of social risk, does disclosure then lead to service connections? Does a connection to social services then lead to a change in social risk? And finally, does a change in social risk lead to a change in healthcare utilization, or health equity? Despite the evidence gaps, this is a pathway that we've seen in the field for quite a while. So for instance, Gurevich and colleagues illustrated this screen and refer framework in 2020 in what they called the OASIS framework. I really appreciated this model when it was published. I know it's a little bit hard to see, but I'm going to highlight a few things for you that I really liked. The team called out some intermediate outcomes that I think are really important. They highlighted competing demands, stress, medication adherence, and they called out that health equity should be an explicit clinical outcome that we examine in the research. I also loved that this team drew arrows, which you may or may not be able to see clearly, but they drew them in different colors to indicate where there was not yet robust evidence or there was robust evidence supporting each model component. I felt like it was a perfect invitation to update the model as more evidence accumulated. And now it feels like the evidence has indeed accumulated. The first thing that made us scratch our heads about the foundational social services pathway that they depict in that model was way back in 2016, when we were looking at the results of our own first big trial of social services navigation, which was based in both pediatrics urgent care and primary care settings. In that study, we found that navigation contributed significantly to both a change in social risks, change in parent-reported child health, but curiously, we also found that the change in social risk only partially mediated those changes in child health. So some people we saw a change in their social risk, some people we saw a change in the child health, but it wasn't always the same people where we saw those changes occur. Flash forward 7 years to 2023, where we saw the results of the CMS Innovation Center's Accountable Health Community Studies, sometimes called the AHC. That study involves 29 sites across the United States, funded to conduct social risk screening with eligible Medicare and Medicaid beneficiaries, and then refer patients endorsing specific risks to relevant social services. Many of you will be familiar with the demonstration's 2 tracks, but just as a reminder, the assistance track involved a randomization after screening that helped to test the impact of screening and referral services. The alignment track, patients were not randomized. It tested the same services combined with engaging key stakeholders and community level improvement. So just looking at the RCT results, I want to flag something from the second evaluation report. And that's that in that assistance track, the results did not show a significant difference between groups. And again, these groups were randomized between groups in receipt of social services or a change in social risk. But they did show a significant difference between groups in the study's healthcare utilization outcomes. So we took our own trial results from 2016 and the results of this much larger AHC study, and we started asking, what else is happening in the middle? What could be explaining those health and utilization changes that we're seeing in these studies? And as researchers, we began to answer those questions by going back to re-examine some of the other literature that seems to have been giving us clues all along. And here's what we found. So first, in several qualitative studies, we started to recognize that researchers had described parents and patients and navigators' input about something that we are referring to as an emotional support or healing relationships pathway. This emotional support healing relationships pathway seemed to occur whether or not the initial conversation about social risk led to social services referrals or whether it contributed to changes in social risks. So this helped us to define this pathway where just discussing social risks may lead to health via a sense of emotional support. This is a quote from an adult caregiver of a PEDS patient that was enrolled in that early RCT I mentioned in the Pediatrics Social Care Navigation Program. Just knowing that someone cares, even if I didn't need anything at the time, just her calling to check up on me was really nice. That's nice to have people in the community reach out and see how you're doing. Sometimes you feel alone, you know? It wasn't just in our study that we found this. A research group at UC Berkeley, led by Mark Fleming, also has described this pathway about healing relationships. Their group at the time was studying the impacts of Community Connect, a social needs case management program implemented at Contra Costa Health Services under the California 1115 waiver in Medicaid. Each of 70 case managers in that program served approximately 90 patients at a time. In their paper, Mark Fleming and his colleagues quote multiple patients, including one whose quote is here on the screen. I'll just highlight that last line where the patient said, "She made me feel like a person." Again, this emotional support healing relationships pathway is not a surprise, but we felt like it's important to recognize the growing evidence base suggesting that these relationships may augment the impact of social services, referrals, or connections, but they also seem to operate independently from those connections. That same research group also reported another mechanism through which their case managers contributed to improving health. They emphasize that the ability to overcome systems fragmentation and administrative obstacles meant that not only were navigators connecting patients to social services, but they also seemed to have a lot of success connecting patients to healthcare services that had somehow felt inaccessible to patients before. They helped patients both schedule and present for medical appointments and ensured patient eligibility for those services. So the idea that social services navigators are not just connecting people to social services, but also connecting them to healthcare services certainly appeared in other studies too. Many of you will be familiar with a series of studies that Shreya Kangovi and her team have published on IMPACT, community health worker intervention. In one of her RCTs, Shreya reports that almost 25% of study participants reported that the most helpful component of the community health worker intervention was support for establishing primary care. We heard the same point from patients in the study that Ali Arenstam led of our pediatrics-based social services navigation program too. Only in that case, the intervention not only helped adult caregivers attend to their child's healthcare needs, but also helped the caregivers prioritize and attend to their own healthcare needs. The final mechanism we found in the literature suggested that information about social risks, assets, and needs could also influence clinical care decision-making. This is a pathway that the National Academy of Sciences, Engineering, and Medicine had included in a 2019 report on integrating social care into healthcare delivery. But we started seeing it described in many different settings. So as one example, in a study of primary care clinician experiences with social screening, Tong and his colleagues in 2019 said physicians reported the social risk data changed clinical care decision-making in almost a quarter of their encounters. Another group in Michigan showed similar things, specifically looking at care decision-making for patients with diabetes. So in these cases, the changes were focused on reducing the impact of social adversity on the patient's ability to manage their disease. And you can see the types of examples that the clinicians suggested in this table. Other work focused on tailored care comes from Saul Wiener and Alan Schwartz, who have shown not only that paying attention to context changes care and leads to clinically meaningful health outcomes, but also that you can effectively train clinical teams to better attend to social context. Okay, so with all that in mind, we set to work on trying to put all these different potential things in the middle into a more comprehensive visual to depict what we were learning. So this is the new visual where we include in the top row the familiar foundational pathway that travels through connections to social services and decreased social risk, as well as pathways that run through emotional support, healthcare services connections, and tailored medical care. Of course, in putting together this simplified model, we had to make some trade-offs. And here I want to come back to the point I made in the introduction, which is that every model is either wrong or at the very least can be improved. So we, of course, ran into these big challenges, these big trade-offs. For instance, how much detail should we include in the model? How many boxes does the model need to be useful versus become unwieldy? So as an example, this is a version of our first version of the model as we were playing with it. Here, I really want to give a shout out to Megan Sandell, my mentor and friend from BMC, who many years ago convinced me that the best models are those that can be reproduced on the back of a napkin. So we ultimately opted not to create a super busy model with a lot more detail about each step, and instead went with a more simplified version. Some other trade-offs that we made, it ended up meaning that we left out some things that others might want to measure or emphasize when they recreate this model. So for instance, stress is probably relevant to each of these pathways. So maybe it should be inserted before we get to improve health and decrease avoidable healthcare utilization. In another example, we struggled with where to put racism and discrimination, which we believe are likely moderators all along the different pathways to health. Where should we put them? And then, of course, we could have called out equity as its own outcome in that final box, as opposed to just a subset of improved health and decreased avoidable healthcare utilization. Along those same lines of how many boxes, we also struggled with how many arrows to include in the model. Many of the steps are interconnected. If you change social risk, you likely also change the likelihood of accessing healthcare services. If you have meaningful relationships, you change the likelihood of accessing healthcare services. We could have had a lot more arrows. And similarly, we wondered whether we should make all those arrows multi-directional, or as a colleague from the City of Hope suggested just a couple of weeks ago, maybe we should have made the entire model circular and stop thinking inside the box. It could have looked like this. But you can see how the visual starts to become a little less useful with all the arrows and all the bidirectionality. Ultimately, I will quote Seth Berkowitz to say that we opted for both a parsimony of boxes and a parsimony of arrows. So all that said, our hope is to open this up to hear from some of you about the evidence you all have found in the field that feels relevant to these pathways and or other pathways that maybe aren't yet reflected in this visual. Before we do that, though, we thought it would be important to just mention what we at SIREN think the potential policy, practice, and research implications of this new model might be for applying this work to, or this research to the work that's being undertaken in the field. So with that, I'm going to turn it over to Caroline.
Yeah, thanks so much, Laura, for walking us through how we came up with this model and the different elements. So I'll touch just briefly on some of our thoughts around the implications for practice and policy. I think the biggest implication is, so far, as Laura highlighted in the beginning, the focus of many of the health-related social needs interventions has been on this idea that we identify needs and therefore we connect people to resources to address those needs, and that's how we improve outcomes and reduce inequities. We think that this model suggests that we may be underinvesting in elements of this model that could actually help improve the impacts. So specifically that we may be under investing on those three other pathways. So the opportunity to provide emotional support, which, as Laura highlighted, can have all sorts of impacts on other aspects of people's lives. The ability through navigation to help increase the connection to healthcare services, which again can have a big impact on health and healthcare outcomes. And then also, and I think this is an area that particularly doesn't get enough attention, the idea that this information can be used and should be used by the healthcare team to ensure that the healthcare that's being provided is not being negatively impacted by the risks, the social risks and needs that patients have. So it feels like one of the big implications here for practice is, there's been a lot of focus on referrals. There's a lot of focus on referral platforms. And that's an approach that probably doesn't provide the emotional support or doesn't link back to healthcare to help a healthcare team or doesn't automatically do that versus an approach that's using a navigator or social worker or a community health worker, which may be able to do a lot more of these different pathways, like through the same mechanism. So we think that it would be really important to start thinking about these different approaches to addressing social risks and how each of these may or may not provide an opportunity to address these pathways. I think the other implication for practice is, one of the big, I think, challenges implementing these health-related social needs interventions is that there's a lot of resistance, understandably, in healthcare settings to screening for something where there's not a clear, necessarily set of resources that can be provided. And I think that this, thinking about these interventions in this more comprehensive way, I think may help people maybe feel a little bit less resistant to the idea of screening for social risks, because it means that even if you're just using that information to improve the healthcare that's being provided, you may be providing a benefit. So we don't have to think necessarily of all the benefits having to go through that top pathway. So I'll stop there. These are just some of our thoughts. We're really excited and interested to hear more of yours. And again, as a reminder, please put any comments or questions you have in the Q&A. I'm going to pass it over now to my colleague Danielle to share some reflections on implications for research.
Much, Caroline. Thank you, Laura. In thinking about the implications for research, we think there's at least a few, and I am so looking forward to your questions and your chat to help us think through even more. The first one that came to mind is just the simple what we are including as we include measures and we think about how we approach our research. So a lot of times we're thinking about having a parsimonious set of measures, whether it's quantitative or qualitative, really focusing in on our key research questions, the pathways we're thinking about. And as you've heard today, that first pathway at the top is the one that has really been receiving a lot of the attention, a lot of the love in the field. And so looking at this model, one of the things that I've been thinking a lot about is where the opportunities are for increasing our measurement of some of these other pathways through different, whether it's quantitative, through existing resources or new measures, as well as qualitative, if we're asking the questions that are pulling for the whole content for all these different pathways to allow this evidence to emerge. And then just because we measure it doesn't mean we actually evaluate it. So the next implication that we were thinking about is how we evaluate our social care interventions. There's so many times that I've seen randomized controlled trials measure a lot of great things and they stop at this early stage, and I have done this as well in the past, of saying, here's my primary outcomes, here's my secondary outcomes, but they don't go on to really look at the mechanisms. And as you heard Laura explain early on today, just because we have improvement in decreasing social risks, just because we have improvement in health, doesn't mean that that was the mechanism by which identifying our unmet social risks led to these outcomes at the end. So it's really important, again, that both quantitatively and qualitatively, we're thinking about peeling back and understanding that really interesting what happens in the middle. What are the mechanisms by which these things are connected? And then last, all of this can really help us understand and shape what to test, what interventions are we seeking to implement and to evaluate. And so in addition to those that are already out there and the great work that's occurring, thinking about this model has helped me take a step back to think about, well, what are the interventions? What are the different pathways here that we would want to test? And would we want to strengthen up, to sort of bulk up on different interventions? Would we want to test them head to head with that first pathway? And also, is it even possible to test pure interventions? It's, say, a 4-way randomized control trial. Or do we really need to wrestle with and acknowledge how these are interrelated processes, and to think about key interventions that maybe we're overlooking or not focusing on enough that can have a lot of impact here for health and health equity in the end? So with that, I want to thank you, and I'm going to turn it back over to Caroline for moderating our Q&A.
Great. Thanks so much, Danielle. And thanks everybody for the questions. As a reminder, please put your questions in the Q&A, not in the chat. Fabulous. So I'd love to start with this one question. There's great questions in the chat, and hopefully we can get through a lot of them. What David Alward brings up a question about, what do we know about the differential impacts on who, right now our model kind of treats everybody the same. It doesn't really distinguish between some people may respond to this better than to that kind of an intervention. What do we know about differential impacts in different groups? Do we know anything? I guess would be a question around some people responding better to some approach versus another. Any thoughts on that? I know that's a hard question.
So, well, I'll take a stab at it, and hopefully Danielle and Caroline, you guys can jump in. In the SIREN report that we put together in 2022, I think it came out in the summer of 2022, we actually looked at people's the acceptability of screening to patients in many different settings. And some of those studies actually looked at the acceptability of screening in subgroups of populations. The Accountable Health Communities recently has looked at it across subsets of patients too, and I think some of that will be available in the third evaluation report. Not all of it is available yet. In the SIREN report, we talk about how we didn't actually see significant differences between different racial and ethnic and minoritized groups, which was interesting. It was unexpected and it was super interesting. I think there are some other studies that have found some differences, particularly in some of the qualitative work. But in the quantitative work, I think we haven't yet seen any differences across groups. We also didn't see differences by age group, gender, or language responding to the surveys. I think there's a lot more research that needs to be done around the acceptability of screening in different subgroups. The question is not just about screening, though. I think it's also related to the acceptability of interventions, and to be totally transparent. I really think that third report of the Accountable Health Communities is going to give us some more information about the acceptability and the impacts of the interventions in different subgroups. But I'm not remembering at this moment that there have been other very large studies that have actually looked at the acceptability with sufficient power, like enough numbers of people in different subgroups that we can actually discern a difference.
I can add also a little bit to that. I know that when we funded some small projects to look at the interest in assistance. And I think one of those studies really stood out to me where they tested the impact of a web-based platform that people could navigate themselves. And they've definitely found differences in terms of there were people who were very comfortable with technology, and for them, that platform really worked for them, and that tended to correlate with age also. And then folks that were much less comfortable with technology really didn't engage with it. So I think that there is, and I think that there is in the second evaluation report of the AHC model, actually some differences by race ethnicity in terms of responses to the navigation that were interesting, but not in terms of, I think, of the overall impacts of the model.
Actually, you're reminding me that in that, I think actually it's an encouraging finding. It's that Black and Latinx patients were more likely to connect to services and more likely to report a change in social risk, if I'm remembering it correctly. But which was, again, to me, a surprising finding.
And brings up again kind of how, the complexity of trying to think about these kinds of multifaceted interventions.
I'll
go ahead,
layer, well, and I'll just layer on, as more and more research is emerging in this area, one additional context is the modality of how it's being asked. So for instance, is screening occurring electronically? What is the access to that? Is it through a portal? Is it verbally? Is it with a trusted individual of the healthcare team? Is it AI? And so those considerations as well, I've started to see some differences of where their differences they exist, in what direction may also be linked to some of those modality of how it's being asked and by whom.
That makes a lot of sense. There's a great question in here. I mean, all the questions are great, but here's a question that's really interesting. And I don't know if we have any responses to this, but I'm going to ask it anyway, because I think it's important to highlight it. So Vincent Grande asks, the types of social needs can range a great deal. Is there any evidence for different mechanisms of improving social risk depending on what specific needs people have or the chronicity of the need? Have any of you seen anything related to that? I don't feel like I have. So that's an open research question. If anybody has seen any of that, feel free to drop it in the chat. But I think that's a really interesting one to think about.
I love that question. I think, there's an intuitive response, which is that the relationships will be more important for more chronic needs. That there's a potentially underlying reasons why the need is chronic, and then that some of the more severe needs or intractable needs, like we need to think about some of the other mechanisms. I think it's intuitive, but I haven't seen any research that's actually looked at it.
I agree that would be a fascinating question to look at with these different pathways. And I think where we have seen in the literature is the cumulative number of social risks. And in some of the individual pathways, where it has been examined, often it's in the direction of larger impacts when you start with a higher number of social risks. But no head-to-head comparisons that I know about saying like one pathway is relevant for one risk or more risks.
Thank you. We have a couple questions coming in around technology and kind of the use of technology to help facilitate resource connection, since that's been one of the main approaches that a lot of healthcare organizations are using. So to what extent can technology imperatives complement efforts to build the relational capacities that are context sensitive And to what extent might a tech focus actually be at odds with the key ingredients of equitable process? Again, hard question, but any thoughts about that? And then related to that, somebody else has asked about the idea of personalized pathway platforms, if that's something that either of you have come across.
Well, actually, Caroline, I think you should tackle the question about technology, because you've actually done several studies on the platform.
Yeah.
And the uptake of the platforms, and talk to people about the benefits of the platforms and also their drawbacks. So do you want to start with that one?
I can a little bit. I mean, I feel like the jury is really still out on the ways that we can best use technology to complement rather than as a sole solution. I think in the work that I think it's clear that referral platforms are not kind of the panacea that many people were hoping that they would be. And there are many reasons for that, but several of them are just, there's a lot of different tools that people have to use already, and it's hard to add another one. And so it's a burden to use for many people. And then I think, interestingly, one of the resistance to using these referral platforms in the context of social service referrals, I think relates a little bit back to our model. And that's the idea that oftentimes people already have established ways of making referrals to other organizations that often involve more of the interpersonal. So pick up the phone and have an actual conversation with someone. And I think just in the same way that our model highlights the emotional support side of having an interaction with another human being, I think that there's a preference as human beings to have interactions with others in the context of doing our work. So I think that that's one of the challenges to that application. I'm still hopeful that there is I think that there still is a role for definitely making the transfer of information more efficient, but I think that we're not there yet. Thankfully, I think there's a lot of experimentation going on across the country with these platforms, and we're going to learn more as we go. And so we're excited to see where that goes. That is what I would say about that. Danielle, Laura, anything you wanted to add?
I think, Danielle, connections to health is also a kind of an interesting other model, because I think Caroline's mostly talking about the technology platforms that involve, here's information about social services in the community, but you've been using technology in other ways too to prompt conversations about social risk in clinical settings, which may be kind of helping with that emotional support pathway and with the referrals pathway, and maybe even all the pathways. Is it worth mentioning that?
Yeah. Thanks for calling that out. Yeah, I mean, I think we're all struggling, right? Of like where and when and how to use technology, like what for each person, for each interaction, what's the best fit. And what Laura's mentioning is there's work I've been involved in a program called Connection to Health, where the idea is at the core relationship building and centering the relationship building and using technology as light prompts to ensure that we're bringing we're trying to bring our best of the conversational tools to build on that relationship rather than the rushing straight to the solution, right? Straight to the action plan, straight to the let's get you on your way with the next step that you're going to take, because often folks have really, really good reasons for not having made a call to a certain agency or you taking the time to hear what happened when a connection didn't take place. And so that's another example where technology could attempt to support relationship building rather than be at odds with it.
The one thing that I might add, kind of along those lines, is that the team at Ochin and SIREN have been collaborating with actually a group. Yeah, it's actually just Ochin and SIREN have been collaborating on a project called Cohere. I'm getting my studies mixed up. But the Cohere study is actually looking at something similar to what Danielle was just talking about, which is using technology, in this case, the EHR, to provide information about social risks at the point of care to inform clinical decision making, to inform shared decision making between the patient and the clinical team. And that's another way, separate from these big technology platforms that are focused specifically on just providing information about social services. There may be other ways that we could prompt some of these other pathways, or movement on some of those other pathways. So I think there is a lot of work out there. We don't yet know what the best uses of technology are going to be in this space.
And there's a couple of comments in the chat that I think are really interesting around technology as well. Eric Fliegler mentioning that maybe AI, where there's kind of a real life appearance of someone, could make the technology more effective. Someone mentioning that the technology is likely to be less accessible in communities that already have fewer resources, and therefore accelerating inequities. So thank you for those comments in here. There's been a string, I feel like, of questions around what do we know about the differential impacts of different kinds of people doing navigation. My sense is like we don't really have good studies on that yet. Is that also your sense, Laura and Danielle? So comparing a community health worker to a social worker, to a peer navigator, those kinds of studies.
Danielle, go ahead.
Yeah, no, I was just like going through my mental Rolodex and I mean the first thought that Laura can of course chime in here with everything that I'm overlooking. My first thought was so many of the healthcare contexts where I'm working, folks are trying to dig in and do this work wherever they can and whoever on their team. And often this is with community health workers, and we're learning a lot about the successes there and some of the amazing work that's occurring and why that can be so successful and impactful. But I have not seen, like, again, a comparison, a clear comparison there of saying, you know, here's a role that's better, more about within a context, where are the available resources and what makes sense. Laura, sorry, what were you going to say?
No, I'm 100% in agreement. We haven't seen head-to-head comparisons, or I haven't seen head-to-head comparisons of, you know, for instance, a volunteer student navigator versus a community health worker, because so much of the decision about whether to invest in a career navigator versus a volunteer, for instance, is related to available funding. There are some interesting models coming from places like Rush, where they're hiring teams of, and actually I think they're doing this with Oak Street Health, now CVS, where they're hiring teams of community health workers and social workers and tiering patients according to need. So that might be an interesting model to follow. The other example that occurs to me, I'm trying to remember, there's well, I'll leave it at that because this other one is too gray for me, but I do think that there's a lot of opportunities there. There is a big question about whether or not somebody could do that study, because ideally, you need a lot of resources to hire more people and then do direct comparisons.
Great. Another question is about the term connection to resources, and asking about kind of how would we define that? That can mean different things. Do we think that there's the same impact, for example, from handing somebody a resource sheet versus actually providing navigation? Any thoughts on that? Laura, I'm thinking here, and Danielle, to the second RCT that you guys did.
Danielle, you want to take it?
Well, yeah. So first on, I mean, first on the definition, I think this is where, like, I want to take the model, right, and I want to like have an accordion, that slide that Laura showed, where you can take it and you can define it in different segments. So there's the provision, for instance, of resources, whether or not that's a resource sheet or orally hearing about the resources. There's the what happens next. Do you have navigation support? Are you on your own? What's occurring? And then you get to the resource. Are they available? Is it what you wanted? Is it helpful? Is there some sort of quote connection there? Are you receiving anything on the other end? And so we can go on and on, right, in the definition of saying, okay, this is a big umbrella connection to the resources. Then to the second point that I'm hearing around, okay, well, yeah, let's unpack that. What are the comparisons? Many of us, including Laura and myself, have been involved in a few RCTs comparing written resources, a resource sheet, to navigation. You have the sheet, you have the resources, and you have a human being who's working with you over time, with that continuity of care over time, who's working to go through those resources, connect. There may be greater involvement, like writing letters, filling out forms on your behalf, or working collaboratively with you, rather, to do those things. And so there's some, you know, there's some mixed evidence there, in terms of there have been some moments in the literature where it does look like navigation has provided additional benefits. And then there have been some times where we are seeing conditions where both of those intervention options, the written resources and the navigation, are leading to roughly equal benefits.
Including our RCT.
Yes. With our most recent RCT.
I wanted to elevate just one comment in the chat. So Kate Johnson, thank you so much for chiming in. Kate's pointing out that in the AHC study, again, the largest study to date of navigation program in the United States, she was pointing out that anecdotally, there were some differences across sites around the type of person who was doing the navigation services. And so it may be worth going back and looking at the second evaluation report. Actually, some of that might have been in the first evaluation report. Thanks, Kate.
So there's a couple questions in here that are around the idea of, you know, it feels like even if there are these other kind of pathways that aren't the resource connection pathway, there's a need to still address that resource connection pathway. It feels like you can't do this without at least doing that. And there's a comment specifically about someone getting feedback from, I think, their board, saying, you know, we can't, there's no point in doing that because we're not going to be able to meet the needs of patients because they're just, the resources aren't there. So for example, the issue of housing availability and affordability. Laura, I know I've heard you talk about that kind of thing before, Danielle as well. Kind of like what do you say in response to people who say, well, there's no point in doing that if we don't have the resources available on hand to address all the needs we're screening for?
Yeah, I love this question. Thank you for pulling it out of the, what is a great Q&A. Thank you all so much for your good questions. I think it's a really important ethical question. Should we not be doing this work if we can't connect people with resources? And that's actually was part of the impetus for putting this model together, because I think we've heard this debate in the field. And I think it's an outstanding question. outstanding mean not answered and really good. Like use your definition of outstanding, however you want to use it. I think that this issue of, do we screen? Is it ethical to screen for something that you can't quote unquote resolve or cure? Is super interesting, particularly because there's so much that we do in the healthcare system where we actually are not resolving or curing. And in this case, particularly, I think because there are other things that we can do with the information about patients' social conditions, we may be letting ourselves, and I'm a clinician, so I may be letting myself off the hook for improving the quality of my clinical care if I don't find out about these important questions, even if I can't solve or resolve them. And this is, again, this is an open debate. This is just my personal opinion. But I think if I prescribe a medication to somebody that is too expensive for them to afford, I need to know about that. I need to know about their financial insecurity so that I can either support them to get the medication in another pathway, another pharmacy, or select a different medication, or prescribe it in a way that makes it accessible or affordable to them. There's a great special issue of Annals of Internal Medicine that's completely dedicated to cost-sensitive prescribing as just one example. There are other examples. I think the examples that were in that Centeo Veno paper about caring for patients with diabetes shares many of them. So my personal opinion is that some of what we need to do is to change the opening script about why we're asking for social conditions. Antoinette Schoenthaler in New York and her colleagues provided a sample script in one of their papers where they're starting the conversation about social determinants as a setup for shared decision making. And I just pulled it up from my email when Caroline asked that question because I liked it so much. It's about, we want to know about this because we're committed to partnering with our patients to help incorporate, more or less, to help us incorporate information about that into the care that we provide. We ask because we care. Now, that doesn't mean I'm going to connect you with all available social resources. Maybe I will, because ideally, I'd like to help you decrease these social barriers to health. But there are other things that I can do with that information that may make care more accessible and affordable. Danielle, turn it over to you.
Oh, 100%, Laura. No, you said everything and more that was on my mind so beautifully as always. I think I love this question so much. It's really connected to what we're trying to do with the model. And I think the more that we are testing these other pathways that aren't just the one at the top, the more we can hopefully have a clearer sense of the evidence base that we feel really solid with our introductory language that we are bringing to patients of setting expectations for why we are asking and what we are hoping to partner with them on.
And just doubling down on, it doesn't mean that assistance isn't, also is the ethically, maybe the ethically right thing to do. It just means that there may be other things that we can do as well, even in the absence of the ability to resolve a social need.
Yeah, great. I think we'll have time for maybe one more question, and I wanted to highlight one around trust. So somebody asked, are we aware or do we have any thoughts on trust as a possible component within the emotional support pathway? And then a flip side of that is, are there any studies that have documented harms in the patient-provider relationship when the referral services are not provided? I'm not really aware of the latter, but I know that our study on acceptability looked at trust, right, and found that trust with your healthcare provider was positively associated with
Mhm.
higher acceptability of social risk screening. This is a study that Amelia DeMarcus is the first author on. So we think there's some evidence that that does help improve the at least the acceptability of social risk screening. Any of you aware of any studies that have documented potential harms? I can think maybe of some around the acceptability as well, but let you two jump in if there's something you want to add.
I mean, I think that there's several folks that are currently looking, not all of this is published yet, but currently looking at the unintended consequences of our work, right? And so I'm thinking particularly about great qualitative work that many of our colleagues, particularly on giving a shout out to the Ocean team here and Arvin Garg and colleagues who've been looking at unintended consequences for many years now, and so, you know, not just designing our qualitative questions to pull for what we're hoping to hear are benefits, but really delving deeply into the different harms that have occurred. One is the one that was named around connection to resources, but others all along the way. You know, why was I asked these questions? Why was I singled out to be asked these questions? Why was I provided care in the way I did? Did it impact my care in other ways? You know, so there's so many questions that we need to be asking along those lines.
I think that might be a good place to end. Oh, Laura, sorry, you were going to add something.
All good, all good. We can leave it at that. I know it's time.
Okay, well, want to thank all of you for all of your great engagement and questions. I'm sorry that we couldn't get to all of them. I love that you all were talking to each other and engaging with each other around this. Want to remind you again that we have 2 upcoming webinars, and if we can put the link in the chat to them once more, that would be awesome, Dylan. If you happen to have access to it, there it is. Thank you all, and hope everybody has a good rest of their day. Thanks again for joining us.
Thank you all so much.